this talk relatively briefly entitled The Prelude to Venous Congestion. It's going to be a physiology of the right atrial pressure, and below are my conflicts. So what does the right atrial pressure tell us? We're often asked if the right atrial pressure tells us volume status. Does it tell you about cardiac function? How about global perfusion or tissue perfusion? Depends. You've probably heard these answers, combinations of these answers as to what the right atrial pressure tells us. So what we're going to do is we're going to use the Guyton explanatory model to describe the determinants of right atrial pressure to get a better understanding of actually what kinds of questions the right atrial pressure or central venous pressure can answer. So we'll start here. We're looking at the right atrium here. This is the mean systemic filling pressure, and this is this leveling out pressure if the heart were to stop and blood in all vessels were to come to equilibrium. So the PMSF is usually 7 to 10 millimeters of mercury, and it's species independent. And this would be the pressure that would be in the right ventricle, the right atrium, the left ventricle, all of the arteries, all of the veins. And it takes the 7 to 10 millimeter mercury pressure largely because this is the weighted pressure that is tilted towards the venous volume and the venous capacitance, because the venous volume is roughly 70% of the blood volume. So you can imagine this 7 to 10 millimeters of mercury as being a marker kind of as how much energy is in the peripheral vasculature, how much energy is contributing to cardiovascular homeostasis in the steady state when the heart and the vessels are working in tandem. So if you'd imagine this somewhat artificial experiment where you were at this 7 to 10 millimeter of mean systemic filling pressure, and then you were at a lower right atrial pressure to increase venous return, and you could do that by, say, sucking blood out of the right atrium, but you'd have to simultaneously maintain mean systemic filling pressure at 7 to 10 millimeters of mercury artificially. But if you were to continue to lower right atrial pressure, what you would get is venous inflow into the right atrium as pressure falls, and you could continue to see this increase in venous return as the right atrial pressure falls at this artificially static 7 to 10 millimeters of mercury if you were just, say, sucking blood out of the right atrium and pumping it into a reservoir and not say back into the system. And that would give you this relatively linear venous return curve. And then you can imagine doing the same experiment, but doing it at a greater venous capacitance. So there's general venodilation, so the amount of energy in the walls that is imparted on the blood is less. And then you were to do the same experiment where you were sucking blood out of the right atrium at a constant but lower mean systemic filling pressure. If you're to do that for all the same right atrial pressures as the previous experiment, you would get less inflow relative to the higher mean systemic filling pressure at 7 to 10 millimeters of mercury, which is designated by the smaller arrows coming in through the great veins. And as you can imagine, the next experiment would be doing this at a greater mean systemic filling pressure. So say you've had a sudden decrease in venous capacitance, say by venoconstriction is the wrong term, but a decrease in the venous capacitance, say by alpha agonists that cause the venous smooth muscles to constrict and metaphorically lift the venous blood to a higher energy state. So you've got this higher mean systemic filling pressure, and then if you were to lower the right atrial pressure to say the same, it's not really illustrated here very well, but if you're to draw a horizontal line between these three venous return curves, you could see that for the same right atrial pressure on the x-axis, there would be greater venous return for this state of higher mean systemic filling pressure, and that's illustrated by the greater arrows, the larger arrows moving inwards towards the right atrium. And then you could do this similar experiment where you focused only on cardiac function, and it has a bit of an inverse relationship as venous return, whereas if you increase the stretch, the end diastolic ventricular stress, you get this calcium-induced calcium sensitivity, so you get a greater contraction force, you get greater volume out of the heart for a given right atrial stress, and it follows up this curve, so you get a certain amount of outflow, say through the pulmonic vein here. But if you had a state of impaired cardiac function, and again, I say this quite a bit, but this decrease in the slope of the curve doesn't mean necessarily that there's been a decrease in contractility. It could be anything that impairs cardiac function. It could be a dysrhythmia. It could be an acute valvular regurgitation. It could be an acute increase in afterload. All of these detriments to cardiac function will essentially just diminish the amount of volume coming out of the heart for a given filling pressure. So in this state, there's impaired cardiac function. So for the same filling pressure, there's less outflow through the heart, as depicted by the smaller arrow. And you could make the same argument for an increase in cardiac function. So again, this could be, say, cardioversion from a very rapid AFib to a normal sinus rhythm would cause an up and to the leftward shift of cardiac function curve. It could be afterload reduction for the patient with heart failure. So anything that increases the amount of cardiac outflow for a given filling pressure shifts the curve up and to the left, so you get more outflow for a given filling pressure. And then you look at these functions working in tandem, where you've got venous inflow and cardiac outflow working simultaneously, and you get this balancing point, which is the right atrial pressure, which is this point right here. And so you could imagine a situation for a given cardiac function in the light blue curve that you say you have sudden venoplegia, loss of venous tone, so there's less inflow, marked by the smaller arrows. But if simultaneously the heart was impaired, say acute coronary ischemia, in the situation that's coupled with a decrease in venous return, so you have a decrease in cardiac function, so you've got less coming in and less going out, you actually have a situation where you have a roughly equivalent filling pressure, but at a much diminished outflow. So flow here is on the y-axis, or cardiac output, let's call it. So this right atrial pressure is the same. It's pretty low. We could say that this is maybe, 2-3 millimeters of mercury, but it has significantly diminished cardiac output here compared to the beginning state. And as you could imagine, you could make a similar argument where you have a state of increased venous return, say from diminished venous capacitance, so there's more energy imparted on the moving blood from the peripheral vasculature, shooting the venous blood back to the heart, so to speak, so you have greater venous return. But if you simultaneously had greater cardiac function, for whatever reason, you'd get greater outflow, and therefore you'd have a state, three different states, three different right atrial pressures, three very different cardiac outputs, and three different states of the peripheral vasculature. So this could in fact be different states of volume state. So this could be a relatively overloaded state. This could be a underloaded or hypovolemic state, hypervolemic state, and this nevertheless have the same right atrial pressure. So you have to integrate the way you think about the right atrial pressure in terms of the clinical exam, as well as cardiac function, say gleaned by echocardiography. So you can't just make a decision based on a single right atrial pressure. And the analogy that Sheldon Magner often uses is to think of right atrial pressure as interpreting a pH. You would never just get a pH of 7.2 and think that you know everything about the biochemical state of the patient. That the pH of 7.2 could be metabolic, it could be respiratory, in the same way that a certain right atrial pressure or central venous pressure could be influenced by, say, venous return and cardiac function. So you have to think about these things in tandem when you're making this interpretation. So let's assume for a moment that cardiac function stays stable for a given clinical state change. So we'll say in this situation, the cardiac function is relatively poor with this curve here. So you could see that this patient's slope is diminished, so their ability to respond to additional volume is actually impaired despite having a low filling pressure. And if you were to give this patient, say, volume and increase the amount of venous return, you would increase right atrial pressure along the x-axis, and you'd get a little bit increase in cardiac output, but a rather large increase in right atrial pressure. So perfusion, or at least let's say outflow from the heart, hasn't changed all that much despite there being a large increase in pressure. And similarly, if this patient got more volume, their right atrial pressure would go up even more, and there'd be very little flow augmentation in this particular situation. So again, in this example, as right atrial pressure is rising, it is rising a function of, say, volume state, as there is increased venous return in a patient that's hypervolemic. So in this situation, it would appear that right atrial pressure is correlating with volume status, but the assumption is that cardiac function hasn't changed. And as many of you are aware, cardiac function is quite dynamic in the intensive care unit. So the question is, what does right atrial pressure tell us? Volume status, cardiac function, perfusion depends. And I hope that you realize that it depends, that the right atrial pressure is a very important variable. Central venous pressure is a very important variable. It's not meaningless. You just have to kind of solve it like a crossword puzzle when you're interpreting its value. So there's a couple of ways of non-invasive assessment of right atrial pressure that we're going to talk about. Probably the most commonly used one is in a patient who's spontaneously breathing or triggering on the vent, this idea of looking at collapsibility of the inferior vena cava, because it's relatively easy to insunnate. So you can look at it and you can infer that when the vein is small and collapsing, that the right atrial pressure is low, and that's a fair approximation. And this is a simplified explanation, but you can assume that the x-intercept of the cardiac function curve is the pleural pressure. It's the pressure surrounding the right atrium. And so then you can see in this particular cardiac function, cardiac state that we just talked about for these, say, 3 different states of total body blood volume, that at this right atrial pressure, this PTM, the transmural or the distending pressure across the great vein, so the pressure within the vein, which is the right atrial pressure, the central venous pressure, minus the pressure around the great vein. In the thorax, it's the pleural pressure. In the abdomen, it's the intra-abdominal pressure. So it's a little bit more complicated than this, but this is probably more, this illustration here is more apropos for the superior vena cava, which is an intrathoracic great vein. So this transmural pressure, the distending pressure across the vein, translates to a certain venous volume. And similarly, if the right atrial pressure rises here, let's say in the SVC, the PTM in this brick color rises, and the way that the pressure volume relationship of the great veins appears is it's this similar asymptotic relationship that you see where you have at low pressures, you have relatively large changes in volume on the x-axis, and then as the pressure goes up, the volume rises more on the y-axis, but the distensibility actually starts to diminish as the transmural pressures rise. So this is a very basic overview of why there is a relationship between the right atrial pressure and great vein volume that you can insunnate with B-mode ultrasound. So another emerging approach to qualitatively assessing venous pressure is the use of venous Doppler, and it's being championed particularly by a group in Montreal who's doing really fascinating, exciting work on venous Doppler. The research has been around for a while. There's data that I've seen even in the late 70s that had been looking at the relationship between venous Doppler and right heart function and right atrial pressure. People have, in the 90s, they were using the hepatic veins, the common femoral vein, to do these assessments. So it's been around for a while, but I think the group in Montreal is particularly really been doing really cutting edge work with this in the last 5 years or so. And so a very, very basic and somewhat simplified explanation of why you see a certain venous Doppler pattern with increasing right atrial pressures. You can imagine, as an example, this sort of static upstream pressure as a surrogate for the amount of energy that's upstream in a vessel. And then you have a downstream pressure that is monophasic, monotonic. There's nothing changing. And so you have this velocity that characterizes the flow between the two as a function of the vascular area. And then you could ask yourself, well, what if the downstream pressure is actually varying with time and not monophasic, as in the example above? So you could say, well, what if this downstream pressure has an A wave, a X descent, a V wave, and a Y descent, which you may recognize relative to this upstream pressure, and then you insonate, say, at a great vein that is entering the right atrium, and you would see this velocity pattern that is essentially just the mirror image of the right atrial pressure tracing. So as the atrium contracts at end diastole, you may actually have a little bit of a reverse wave characterizing the A wave. And then at the onset of systole, as the tricuspid valve pulls towards the apex, you have a decrease in pressure, which causes the X descent. So you have this S velocity coming in, and then the tricuspid valve recoils back upwards, yet venous return continues into the right atrium. So you have a pressure increase up into the V wave, and then the tricuspid valve opens, and then you have the Y descent. Pressure falls, and then you have this inflow velocity that you'd see in the venous Doppler. That's the D wave. So in the venous Doppler, you'll see the A, S, and the D. You could add on kind of more distal veins. So if you, this is an oversimplification. There's other reasons why you get portal vein pulsatility than this, but this is one potential mechanism where you have this reflection of the A wave during late diastolic contraction of the atrium, kind of fluctuating back against the portal vein. So you get this light undulating pattern normally in the portal vein, and in the hepatic veins closer to the right atrium, you see the S and the D wave that we just talked about. And then say as the patient's right atrial pressure rises, as the atrium distends and gets filled with blood, the atrium itself becomes less compliant as its volume rises. So when the atrium does contract in late diastole, you have more of this reverse pressure reflection, this pronounced A wave that causes this more pronounced pulsatility, say in the portal vein, and you can see this large reversal of the A wave and a diminished S wave relative to D wave, say in a hepatic vein. And then as right ventricular contractility worsens, so there's less X descent, and or if there's superimposed tricuspid regurgitation where during systole you just have this blowback, you may have a reversal of the S wave in this situation where right atrial pressure is very high. So then you may actually only see the velocity reflection of the Y descent, causing a monophasic D wave in the venous velocity, and this would represent a relatively high right atrial or central venous pressure. And so we can sort of think about how these B mode and Doppler patterns present themselves in basic physiology on the x-axis of the Frank Starling curve. So if right atrial pressure here on the x-axis is very low, you have a small diminutive collapsing IVC, and you have that, say, continuous or slightly undulating pattern on the venous Doppler. And then as right atrial pressure rises, you get more of a plethoric, non-varying IVC that's large in diameter, and you start to see the more prominent venous velocity waveform of the S greater than the D, and then the S less than the D, and then the monophasic D as right atrial pressure rises. But if you think of this in terms of the Frank Starling model, you would know that this information, for the most part, is really only telling you about the x-axis, and it's not necessarily telling you about the y-axis or the amount of volume that's coming out of the heart. As we talked about, it could be quite different for different states of filling. So we could assume that this is kind of a normal situation where you have a giving relatively low right atrial pressure that's continuous with a normal high cardiac output. And if this patient were, say, to become volume overloaded, but this triggers the Starling mechanism, you'd actually have an increase in volume coming out of the heart. So flow or cardiac output rises on the y-axis, and the right atrial pressure rises a little bit. So maybe you go from this continuous to somewhat of a pulsatile venous pattern. In a situation where cardiac function is significantly impaired, here for the same, let's say, volume status, for the same amount of venous return, because cardiac function is impaired, volume status hasn't necessarily changed from here to here, Nevertheless, because cardiac function has decreased, you can see that the right atrial pressure has increased significantly. And so now you're getting this SD wave pattern, and flow on the y-axis has shrunk. So this patient does have less cardiac output. Yet, in somebody with even worse cardiac function, this person could actually have a smaller volume status. So they've got less venous return, but because their cardiac function is so poor, there's less coming out. So this patient has very low flow, despite having the same filling pressure, presumably the same venous Doppler pattern, and relatively same IVC volumes assessed by B mode. So then you kind of have to ask yourself, well, how do I distinguish between these states? And I think one way you can do it clinically is to make this, you could sort of make almost like a 4-quadrant plot, where you could see that even though these two patients or these two states have relatively same filling pressure, patients with greater flow, patients with less flow, how could you distinguish them? Well, the classic clinical exam stuff. So they're warm, they've got a short capillary refill time, they've got normal biochemical markers, whatever that means. And I will not say lactate. Let's say they've got a good LVOT VTI, versus patients down here where they've just got low flow despite having the same filling pressure. This patient would be cool, have a long capillary refill, say they've got abnormal biochemical markers, whatever that means, and say their LVOT VTI is quite low. So there are other ways that you can categorize these patients, and the ways that you should be thinking about how you interpret right atrial pressure, whether you're measuring it invasively or non-invasively. So all that was about right atrial pressure. So how do we get back to tissue venous pressure? Well, that's complicated, but you can sort of ballpark approximate that there's roughly a 5 to 10 millimeter of mercury pressure loss because of venous resistance, say from the venules to the right atrium. So whatever your measured right atrial pressure is, you could add 5 to 10 millimeters of mercury to get a very rough estimation of what the venular pressure would be. Interestingly enough, as right atrial pressure rises, you recruit and distend veins. So you actually kind of decrease Starling resistors, or you recruit Starling resistors, so that venous resistance loss may actually be on the lower end of that 5 to 10 range. So, if you've got hypothetically, if you've got a right atrial pressure of 2, maybe your tissue venular pressure is 12. Whereas if you have a right atrial pressure of 15, maybe the venular pressure is 20, as very, very, very crude estimates. There's also a gravitational gradient when the organ or tissue bed is below the level of the right atrium. The gravitational effects would be similar for the artery and the vein, so gravity by itself would not necessarily affect the perfusion pressure, but the gravitational hydrostatic pressure, so the degree to which the tissue is below the right atrium, could still affect fluid transudation at the venules and tissue edema. So there's also that caveat as well. So this is a final model that I didn't put in my talk because I was just rambling and didn't want to put people to sleep. But this is one way of trying to integrate multiple avenues or multiple different concepts when you're thinking about right atrial pressure, cardiac output, mean arterial pressure, and tissue perfusion. So this is sort of a shrunken version of the Guyton diagram here on the left. And then there's kind of a break, and your x-axis here is entirely pressure. So down here, it's right atrial pressure. As you get up here, it'll be higher, say mean arterial pressure. And so, as we mentioned, when cardiac output was 0, everything equilibrated at the mean systemic filling pressure. But as you increase cardiac output, right atrial pressure falls on the venous side. So the pressure falls as cardiac output rises. And then on the arterial side, the pressure would rise from the mean systemic filling pressure as cardiac output is gradually increased along, we're going to call this total vascular resistance or total arterial input impedance, as a slope relating cardiac output on the y-axis here to mean arterial pressure on the x-axis here. So if this line if this total vascular resistance curve shift down and to the right, that would be, say, an increase in impedance. So for a given flow, there'd be greater mean arterial pressure. If it shifted down or up and to the left, that would be a decrease in impedance. So for a given cardiac output on the y-axis, there'd be less MAP. But this is a way of describing the relationship between flow and pressure. So for this given flow on the y-axis, you get a given mean arterial pressure. And now how do we incorporate regional tissue flow? So this is going to require an additional axis coming out at you. This is, say, the tissue flows through a given organ or tissue bed, and it's going to be described by local tissue conductance. And every organ is going to have a slightly different conductance. The slope of this conductance line is actually also quite dynamic, so that you can imagine the conductance line for the intracerebral arterioles is going to be very different, have a very different slope, and be very reactive, let's say, compared to, say, the conductance slope. Conductance is the inverse of resistance, so the conductance slope of, say, the digital arterioles, or the kidneys, or pick your organ. It's all going to be quite different. So it's very regional. But let's say for this hypothetical purple tissue here, for a given mean arterial pressure, for a given tissue conductance, you get a given tissue perfusion. And another important thing here is that the pressure in this particular tissue doesn't rise from the mean systemic filling pressure. It doesn't rise from zero. It actually rises from the collapsing pressure of this particular organ system. And interestingly enough, the collapsing pressure kind of in general is probably about 30 millimeters of mercury. But the interesting thing is that it's almost always in normal states much greater than the right atrial pressure. So as right atrial pressure rises along the x-axis, it doesn't really get to this collapsing pressure, and therefore it doesn't really, quote unquote, the right atrial pressure doesn't really, quote unquote, impede outflow until it gets higher than this collapsing pressure, which is can be quite high, 20, 25, 30, 35 millimeters of mercury. So you've got to get, right atrial pressure is quite high to get to that collapse pressure before it starts to impair flow. So what were to happen if you were to, say, increase this patient's volume status? So you'd increase the right atrial pressure, as we saw from here to here. Right atrial pressure rises, so that quote-unquote venous downstream pressure rises. But flow or cardiac output also increases along the y-axis. So along a static vascular resistance, you actually increase your MAP from there to there, which then tends to raise tissue perfusion along a static tissue conductance curve. So a couple of assumptions here that as cardiac output increased was that tissue conductance didn't change, total body vascular resistance didn't change, and that is quite an oversimplification. So what were to happen if cardiac function were to be impaired, but at this lower volume state? So we're at the same right atrial pressure that we were here, roughly same right atrial pressure. So quote unquote no change in downstream venous pressure, but perfusion drops cardiac output drops significantly for the same filling pressure. So what that does, again, assuming a static total vascular resistance, that drops your MAP. Assuming a static tissue conductance, that drops the tissue perfusion along its conductance curve. Now, again, this is just massively oversimplified. That as a particular tissue sees less perfusion, it would inherently auto-regulate and change that slope of that conductance curve. It might actually dynamically increase the slope of this conductance curve upwards in this direction, so that for a given MAP, you tend to buffer that decrease in tissue perfusion. But this is just a way of trying to imagine all of these, and these things are occurring simultaneously, instantaneously. And then if you were to look at the same state of cardiovascular function, increase the right atrial pressure some, So now you have a higher filling pressure than here. So you've increased that downstream venous pressure. It's still nowhere near the collapse pressure of the arteriolar bed of this particular tissue, but you've increased the downstream pressure with almost no increase in output. So in this situation, you have a slight increase in MAP, but if that increase in downstream pressure does change tissue conductance, say there's a reflexive, some organs, when their venous pressure rises acutely, there's a reflexive arteriolar constriction. So let's say conductance decreases or resistance increases. So there's this decrease in tissue perfusion. It's not necessarily because right atrial pressure increased and the increase in right atrial pressure decreased the perfusion pressure, as it were. This right atrial pressure is nowhere near the downstream perfusion pressure for this organ system. It is that the increase in venous pressure had this potential reflexive arteriolar constriction in this particular organ system that decreased tissue conductance, and therefore tissue perfusion fell. It fell in the face of rising right atrial pressure, but it wasn't, because of direct vascular impedance that's introduced by the rising downstream pressure. Anyways, I don't know if that makes any sense. Probably no one's listening. Right atrial pressure, multiple determinants. As I mentioned, think of it as like solving pH. B-mode ultrasound and venous Doppler are ways to estimate right atrial pressure non-invasively. Clinical history and physical must be integrated with full ultrasound of the heart to make good judgments. And the effective right atrial pressure and tissue perfusion is complicated. So all this stuff is delineated in Chapter 10 of my free book, heart-lung.org. And as I said before, it's a free book. You get what you pay for. Thanks.